Dyslipidemia encompasses disorders of lipid metabolism that increase the risk of atherosclerotic cardiovascular disease, ASCVD, including heart attacks and strokes. Understanding the classification, diagnosis, and management of dyslipidemia is very important for clinical practice and internal medicine exam success. Dyslipidemia refers to an abnormal elevations of lipids in the blood, typically including cholesterol and triglycerides. These lipids are transported in the bloodstream as part of lipoproteins such as low density lipoprotein, high density lipoprotein, and very low density lipoprotein. Dyslipidemia is a major risk factor for the development of atherosclerotic cardiovascular disease. Atherosclerotic cardiovascular disease is a group of the conditions that are caused by atherosclerosis and that can affect different locations throughout the body: coronary artery disease, peripheral artery disease, and ischemic stroke. Dyslipidemia, by definition, is that abnormal concentrations of lipid in the blood, high or low LDL cholesterol, whereas hyperlipidemia is defined as elevated blood lipid levels, like total cholesterol, LDL, and or triglycerides. Hypercholesterolemia is defined as an elevated total cholesterol of at least 200. Hyperlipidemia is elevated levels of serum lipoproteins like high VLDL, and hypertriglyceridemia is defined as an elevated triglyceride levels of at least 150. The association between high LDL cholesterol levels and increased risk for ASCVD is widely accepted. In patients with elevated LDL cholesterol levels, it is very important to consider secondary causes like hypothyroidism, poorly controlled diabetes mellitus, nephrotic syndromes, and medications like steroids, diuretics, and amiodarone. For patients without an identifiable secondary cause, genetic testing for familial hypercholesterolemia is appropriate if their LDL cholesterol level is 250 or higher, or if the LDL level is 190, or along with a first degree relative who has similar LDL cholesterol elevation or premature coronary artery disease. HDL cholesterol is considered a protective factor against the development of ASCVD. It plays an important role in assessing ASCVD risk. However, a direct causal relationship between low HDL cholesterol levels and ASCVD has not been established. As a result, pharmacologic treatment specifically aimed at raising HDL cholesterol levels is not recommended, and one of the medication is niacin. Elevated triglyceride levels of at least 150 has been shown to independently be associated with an increased ASCVD risk, although it remains uncertain whether lowering triglycerides directly reduces this risk. Causes of hypertriglyceridemia includes diabetes, excessive alcohol intake, hypothyroidism, and medications like steroids, protease inhibitors, and estrogens. Lifestyle factors such as obesity and a high intake of concentrated sugars also contribute to elevated triglycerides. Patients with triglyceride levels of at least 500 without a known cause should be evaluated for familial hypertriglyceridemia. Triglyceride levels exceeding 500 to 1000 can trigger acute pancreatitis. Therefore, triglyceride levels should be measured in patients with pancreatitis, particularly when the cause is unclear. So, no history of alcohol use or biliary disease. Patients with dyslipidemia are usually asymptomatic. However, there are physical findings associated with persistently high levels of cholesterols. They are xanthomas, xanthelasmas, lipemia, retinalis, atherosclerosis, and hepatic steatosis. Here's a 38-year-old man presents to the ED with acute abdominal pain that radiates to his back. He reports nausea and vomiting over the past 24 hours. His medical history is significant for obesity and poorly controlled hyperlipidemia. On exam, his abdomen is tender to palpation, and a small yellowish papules are noted on his buttocks and extensor surfaces of his arms. His blood pressure is 140 over 90 and heart rate 110. Serum triglyceride is elevated at 1100, serum amylase elevated at 400, and serum lipase is high at 900. Which of the following physical findings is most consistent with this patient's condition? Tendon xanthomas, arcocinellus, erupted xanthomas, or xanthelasma? And the correct answer is C, erupted xanthomas. This patient presents with acute pancreatitis likely triggered by severe hypertriglyceridemia. The yellowish papules described on his skin are eruptive xanthomas, which are commonly associated with extremely elevated triglycerides of at least 1,000. Eruptive xanthomas typically occur on the buttocks, thighs, and extensor surfaces. Tendon xanthomas are firm nodular deposits of cholesterol that typically occur along tendons, such as Achilles or extensor tendons of the hands. They are more commonly associated with familial hypercholesterolemia and elevated LDL cholesterol, not severe hypertriglyceridemia. This patient's condition involves extremely high triglyceride levels, making eruptive xanthomas more relevant than tendon xanthomas. Arcocinellus is a gray or white ring around the cornea caused by lipid deposits and is often seen in older patients or those with hyperlipidemia. While it may indicate high cholesterol, it is not specific to hypertriglyceridemia and does not correlate with acute pancreatitis or triglyceride levels as high as those seen in this patient. Xanthelasma refers to soft yellowish plaques that typically appear on the eyelids. They are associated with elevated cholesterol, particularly in conditions like familial hypercholesterolemia, but they are not linked to severe hypertriglyceridemia or acute pancreatitis. A 45-year-old man comes to see you for an annual checkup. He has no significant medical history and takes no medications. He has a family history of CAD and his father having an MI at the age of 52. He does not smoke and consumes alcohol occasionally. His BMI is 27, blood pressure 128/72. He is asymptomatic and denies any health conditions. He has not had any lab tests done in the past 5 years. Which of the following is the most appropriate next step in the management of this patient? Initiate aspirin therapy, screen for hyperlipidemia, order stress tests, counsel on weight loss, or begin antihypertensive therapy. And the correct answer is screen for hyperlipidemia, which is B. This patient is asymptomatic but has a family history of CAD, putting him at risk of atherosclerotic cardiovascular disease. Screening for hyperlipidemia is recommended for men aged 40 to 75, especially those with risk factors such as a family history of early CAD. Identifying elevated LDL cholesterol levels early allows for initiation of lifestyle changes and potential pharmacotherapy like statins to lower the patient's risk of cardiovascular events. The U.S. Preventative Service Task Force (USPSTF) recommends universal lipid screening in adults aged 40 to 75 years to assess for dyslipidemia and to calculate the risk for atherosclerotic cardiovascular disease using the American Heart Association American College of Cardiology pooled cohort equation. Statins are the mainstay of pharmacologic therapy for dyslipidemia and the primary and secondary prevention of ASCVD. Moderate and high intensity statin therapies are used to manage cholesterol levels, particularly LDL cholesterol, to reduce the risk of atherosclerotic cardiovascular disease. The choice between moderate and high intensity depends on the patient's cardiovascular risk profile, age, and comorbid conditions. We no longer recommend low intensity statin. If the LDL cholesterol is at least 190, consider high-intensity statin therapy to achieve at least 50% reduction in LDL cholesterol. So LDL cholesterol is equal to total cholesterol minus HDL minus triglyceride over 5. Here's a case of a 50-year-old man for an annual checkup. He feels well and has no significant complaints. He has a history of hypertension for which he takes lisinopril. He has smoked a pack of cigarettes daily for the past 20 years and drinks 5 to 6 beers on weekends. His BMI is 26. His blood pressure is 140/85. PE is unremarkable. Total cholesterol is 290, HDL cholesterol 38, triglycerides 150. In addition to dietary and lifestyle modifications, Which of the following is the most appropriate next step in management? Cholestyramine, ezetimibe, fibrates, moderate intensity statin, or high intensity statin? The correct answer is E, high intensity statin. The patient has a calculated LDL cholesterol of 222. LDL is equal to total cholesterol, which is 290 in this case, HDL 38, and triglyceride over 5, which brings down to 30. So, given this formula, the correct answer is an LDL total cholesterol 222, which is above 190. This is a significantly elevated and places the patient at very high risk of atherosclerotic cardiovascular disease, especially given his smoking history and hypertension. Statin therapy, in this case, a high intensity statin, is the first line treatment for patients with LDL cholesterol of at least 190, as it effectively lowers LDL and reduces the risk of cardiovascular events. If the LDL cholesterol is between 70 to 189 and the patient is between 40 and 75 years of age and is not diabetic, the next best step is to calculate a 10-year ASCVD risk score. If the risk score is at least 7.5% but less than 20%, consider a moderate intensity therapy to achieve an LDL cholesterol of 30 to 49% reduction. If the ASCVD risk is more than 20%, then consider a high intensity statin therapy to achieve an LDL cholesterol reduction of at least 50%. If the LDL is between 70 to 189 and the patient is between 40 and 75 years old and is diabetic, the patient should at least be on a moderate intensity statin therapy. A high intensity statin is considered in this case if the patient's ASCVD 10-year risk is at least 7.5%. A 48-year-old man with type 2 diabetes is here for a follow-up. He was diagnosed with diabetes 3 years ago and currently takes metformin. He does not smoke or drink alcohol. His BMI is 28, blood pressure 130 over 80, A1C 7.2%, total cholesterol 210, HDL 45, triglycerides 160, and LDL 140. His 10-year risk of cardiovascular disease is 10%. In addition to lifestyle and dietary modifications, which of the following is the most appropriate next step in managing this patient's cardiovascular risk? Fibrate, ezetimibe, statin, or niacin? And here the correct answer is statin therapy, which is C. Patients with type 2 diabetes are at increased risk for cardiovascular disease, even in the absence of significantly elevated LDL cholesterol. Current guidelines recommend statin therapy for all patients aged 40 to 75 years old with diabetes, regardless of baseline cholesterol levels, in order to reduce cardiovascular risk. This patient's LDL cholesterol is 140. While mildly elevated, it is not the sole factor in recommending statin therapy. The primary reason is his diabetic status, which makes him a candidate for statins for primary prevention of atherosclerotic cardiovascular disease. Ezetimibe and PCSK9 monoclonal antibodies can be add-on therapy for primary prevention in patients with LDL level of at least 190 or who do not achieve 50% reduction of LDL cholesterol on high-intensity statin. It is also important to note that both niacin and fibrates are not recommended as an add-on therapy to a statin to reduce LDL cholesterol levels. A 52-year-old male is here for a routine checkup. His family history is significant for CAD and his father, who had an MI at the age of 55. The patient's diet is high in saturated fats and he leads a sedentary lifestyle. Blood pressure is 130 over 85, BMI 29. Total cholesterol 250, LDL 194, HDL 40, triglycerides 200. Which of the following is the most appropriate initial pharmacologic therapy for this patient to reduce his risk of cardiovascular events? Fibrates, niacin, HMGA-CoA reductase inhibitors, bile acid sequestrants, or ezetimibe? The correct answer is HMG-CoA reductase inhibitors. This patient has elevated LDL cholesterol, a significant risk factor for coronary artery disease, especially given his family history and lifestyle factors. The most effective initial therapy to reduce LDL cholesterol and to lower cardiovascular risk is HMG-CoA reductase inhibitors, also called statins. Statins reduce cholesterol synthesis in the liver and are first-line treatment for hyperlipidemia, especially those with elevated LDL levels. Fibrates, particularly fenofibrate, are most effective pharmacotherapy for hypertriglyceridemia, leading to a 30% to 50% reduction in triglyceride levels. These agents are recommended for patients with severe hypertriglyceridemia of at least 500 in order to reduce the risk of acute pancreatitis. Niacin is the wrong answer in this clinical vignette since niacin is no longer recommended and has no role in lipid management. In fact, evidence from clinical trials do not support its role as an add-on therapy to statins. Cholestyramine is also the wrong answer. Cholestyramine is a bile acid sequestrant that can be used to lower LDL cholesterol. It may be considered in patients who are taking maximally tolerated doses of a statin and ezetimibe, but LDL cholesterol levels has not reached the desired goal reduction, but never initial therapy. Ezetimibe was also the wrong answer. Ezetimibe is not used as initial therapy for hyperlipidemia. It may be added for primary prevention of ASCVD in patients with an LDL cholesterol of at least 190 who do not achieve a 50% reduction in LDL or have an LDL level of more than 100 despite being on maximally tolerated statin therapy. What about secondary prevention? Patients with an established atherosclerotic cardiovascular disease should be on a statin for secondary prevention. These patients may have history of MI, acute coronary syndrome, stable or unstable angina, stroke, transient ischemic attack, peripheral arterial disease, or aortic aneurysm. A 62-year-old male reports no current symptoms but has not had any medical follow-up since experiencing a myocardial infarction 6 months ago. He quit smoking 6 years ago and leads a sedentary lifestyle. His blood pressure is 135/80, a BMI of 29. Metoprolol and aspirin are prescribed and a follow-up appointment is scheduled. Which of the following is the most appropriate additional treatment? Colchicine, ezetimibe, high-intensity atorvastatin, or PCSK9 monoclonal antibody? The correct answer is C, high-intensity atorvastatin. This patient had an MI and is at high risk for future cardiovascular events. High-intensity therapy is recommended to aggressively lower LDL cholesterol and reduce the risk of recurrent ASCVD events. Statins have been proven to reduce mortality and improve outcomes in post-MI patients. A 55-year-old female presents with muscle pain and weakness for the past 2 weeks. She describes the pain as diffuse and worse in her thighs and upper arms. She denies any recent trauma or strenuous physical activity. She has hypertension and hyperlipidemia. 2 months ago, her physician started her on atorvastatin for an LDL cholesterol level of 190. On exam, her muscle strength is slightly reduced in the proximal muscles of both upper and lower extremities. CK is elevated at 800, but normal serum creatinine and normal ALT level. Which of the following is the most likely cause of this patient's symptoms? Rhabdomyolysis, statin-associated myopathy, polymyositis, fibromyalgia, or hypothyroidism? In this case, the correct answer is B, statin-associated myopathy. This patient presents with muscle pain, weakness, and elevated creatinine kinase after starting atorvastatin, suggesting more of statin-associated myopathy. Statin-associated myopathy is a known side effect of statins, manifesting as muscle pain, tenderness, and in more severe cases, elevated CK levels indicating muscle damage. It typically occurs within weeks to months after starting statin therapy. On the other hand, rhabdomyolysis present with much higher CK levels, often 10,000, and may involve acute kidney injury. While polymyositis is an inflammatory muscle disease, but is less likely here due to the recent initiation of statin therapy. Fibromyalgia is characterized by chronic, widespread pain without elevated CK levels, and hypothyroidism can cause muscle weakness, but is usually accompanied by other systemic symptoms such as fatigue, weight gain, and cold intolerance. Thank you, and this ends my talk on dyslipidemia, high yield key points for internal medicine NBM exam and USMLE Step 2 exam.